forgot to do that. All right. Hi, welcome all. We'll be giving a presentation on a reference application called NHSNLink, which is used for public health reporting. I'm Rick Geimer. I'm the Chief Innovation Officer at Lantana Consulting Group. We do all those things over on the side there, but in this presentation we're going to be talking our work for the National Healthcare Safety Network, or NHSN. Some other things about me: I'm a co-chair of the FHIR work group at HL7, also on the technical steering committee, co-author of many FHIR and C-CDA implementation guides, but most importantly, I have an awesome man bun that's convertible into a more awesome ponytail. So NHSN, basically it's a part of the CDC, and they do reporting for mainly healthcare associated infections, things like central line, bloodstream infections, surgical site, etc. They've got over 37,000 facilities that are reporting to NHSN. Many of them electronically using HL7 standards like CDA and FHIR today. But there's a little bit of modernization that they're trying to do. The current way that NHSN reporting works is we work at HL7, we build consensus around an implementation guide, gathering all the requirements for something like how do we want to report a bloodstream infection, for instance. Then we'll go and build that implementation guide, take it to ballot, get it published, and then once it's published, implementers often have have to implement the implementation guide because it's build the data and push it off to NHSN. Then NHSN will begin receiving and analyzing the data, and then if there's any updates, we go back through that whole process through HL7 again. While this certainly works, it does have some challenges. For one, we have long implementation lag times. Often it's a year or more before you can get an IG, even a STU out through HL7, and some of these have been around for so long that they're actually normative. That becomes even longer and more painful to update. And then when it is out there, the implementers, the vendors and such, are often given a year or two before they actually need to implement it and start sending the data. So you get this issue where from the concept of what we need to the time you actually begin receiving data and can analyze it, clinical practice may have moved on, the requirements may have changed. So that delay from requirements to implementation to gathering and analysis can be a bit of a problem. So I like to think of it that it's kind of like writing a recipe and handing it off to someone and say, here, go cook this for me. And then you just kind of sit back and wait and hope someone decides to cook for you at some point. I think we can probably do better. So it's time that we learn to go shopping for the data, and let's cook that data. Oh, no, that didn't come out good. All right. So, but the approach that I'm kind of describing here that we're working on in HSN is to shift from implementation guides that a vendor implements and sends to doing digital quality measures where folks at NHSN can define what their initial population is, any requirements and such, put that into a measure using CQL and the FHIR measure resource combined with terminology, and place that out there and then use queries against FHIR APIs to pull the information and evaluate that FHIR measure resource against it. Some of the big things about that is we can then pull data in real time and update measure logic in real time. So the way this would work is there would be a measure server that has these measures, and if NHSN either finds a bug or they have a new requirement for some data they need to gather, they can update that, and then any system that is subscribing to that measure server, like the NHSNLink application I'm talking about, will pull that down and be able to evaluate the updated data requirements and such. So basically how it works is the measure itself with the CQL logic in it and the libraries that contain them will have the measure data requirements. It'll say like we need these sets of resources. We can use those then to query FHIR APIs or possibly bulk data as that gets more and more widely implemented. We're finding that we often need to supplement that with some non-FHIR data that we would convert to FHIR and then load it on a server together with what we pulled from the EHR itself. And then we would evaluate that measure resource and produce a report for the NHSN use case. That will include what they call line level data. So basically the actual information that was used, the resources that were used to calculate the measure. Now I do want to be very clear when I talk about measures here in the FHIR measure resource, That's not what NHSN calls the measure. They look at this as a data gathering tool, basically. And all that FHIR measure resource will do is define their initial population and the data that they want sent. Their view of the measure, or the metric, whatever that, depending on who you ask, is something much more complex that is evolving on their back end in real time. As they analyze it, they'll make changes. They'll use things like NLP that don't really fit in a measure resource at this point. So when we talk measure here for developers, I'm talking the FHIR measure resource. If I say measure to folks at NHSN, and that would confuse them if it's not what they see as the measure. So I just want to be clear with that. So some things about this new approach, some benefits. First of all, for public health, what this means is we can now get more timely data, and we can get dynamic measure and updates and data requirement updates. So there's not those big lag times get mostly eliminated, not completely, but a fair amount. We hope that there's benefits for vendors and other implementers, that they, basically, at least for NHSN, they would spend less time implementing implementation guides, and we would hope they could focus that time then expanding their API support for things like QI core and such, which I'll get to in a bit. Providers, hopefully this becomes a less of a reporting burden. Basically, if you can just capture your data through regular clinical practice, it gets in the EHR, and we can pull that data out dynamically. That's great. And this approach, we hope, will serve as an example. It is a reference implementation that people can take and customize it for their own reporting needs as well. And as API support increases over time, you can use that for your own internal use cases. I've heard many times before that a lot of people that work in facilities, they want to be able to use the FHIR APIs for their own uses, but there are some challenges around that because of the state where the APIs are at today. Okay, so anyway, the example implementation of this that I want to talk about is NHSNLink. This is an open source FHIR compliant application. It is powered by DQMs. It can run in the cloud. It can run on premises. Basically, it can be run on natively on a bare metal whatever, or in something like Docker. So a lot of options there for how you deploy it. And basically, it aggregates data, calculates measures, and produces a report and sends the gathered data to NHSN. And we're currently piloting this with multiple sites, not just for NHSN, but a genericized version of this as well for other use cases like SANER and such. So here's a quick diagram of how NHSNLink works at a high level. What we're assuming is that the provider environment, you've got a EHR that has basically authentication set up with OAuth 2, and potentially other systems where we could access resources that maybe aren't exposed via the FHIR API right now. On the NHSN side, we have the NHSNLink application. It's kind of deployed in its own little stack here. As I said earlier, this could be deployed inside of a provider's firewall if you want. It can be run standalone like that, and then reach out to NHSN for measure definitions and such. But right now, the current plan at NHSN is, at least for our pilots, we're going to host it within NHSN itself. That just solves some, potential, issues that are more procedural than technical, shall we say, policy, I mean. But basically, an NHSNLink stack is like this. There's a web interface that is optional, so you can have like an infection preventionist operating the application and running queries as they need. But typically, we expect this to actually be deployed and run on a schedule, like on a cron or something like that, or we would evaluate nightly or monthly, depending on the requirements of the given measure. So when the application starts, either again on a schedule or is launched by person, first thing it will do is authenticate if it's a person, then authenticate against the EHR. It will go out to the NHSN measure definition server and pull down the latest measures that it's interested in. At this point, that measure will get loaded in here. There's basically an internal FHIR server. Right now, we're using CQF Ruler, which is a fork of HAPI that has some more advanced quality reporting support. It's done by the folks at Alphora, like Bryn Rhodes and such. Then we'll go out, because that measure definition will also describe what the data requirements are, what we need to grab from the EHR. So we'll then turn those into queries and pull out, if the measure requires, let's say it's a COVID use case, it's not. But if it were, we would go out and query the EHR for things like, get me all, all the patient's conditions, get me their lab tests, stuff like that, what medications they might be on. Then we take that information back, pass it to CQF ruler, again, and evaluate it against the measure, and that will produce a report. We do have a few things in here, like NHSN rules. This is a NLP application that NHSN has developed that we may add as an adjunct into this to add the ability to get some basically do some more processing of clinical documents, clinical notes, and such. That's why it's a kind of a dotted line there, because it's optional. And also the custom query plugin. We expect every facility is probably going to have different systems that are not FHIR compliant, and we'll have to do a lot of one-offs there. But then the idea is once we get all that stuff in the CQF ruler and evaluate against the measure, we produce a measure report that gets sent to NHSN. So they'll have a receiving FHIR endpoint that will receive a FHIR measure report resource. Or rather a bundle with a bunch of measure reports and the line level data along with it. And then NHSN can load that into their main application, which is something that sites, facilities that we're reporting will go and be able to look and see at the data that they sent, what the result of the analysis was, get a lot of feedback about their clinical practice, et cetera. And like I said, there's that rules engine there as well, which currently is residing separate, out at NHSN. Like how I described, we might bring it into here as well, but there's a lot of logic and stuff that can go on there. So, but there's still some challenges. Some of the big ones are that EHRs right now are missing a lot of key resources in their API or resource support in their APIs that are needed for public health reporting. The poster child that we ran into very quickly was the lack of medication administration. US Core requires medication request. QI Core has medication administration, but it hasn't been widely implemented yet. I just think about it. You remember in the early days in the pandemic when you walked into the store and there was no toilet paper but a lot of paper towels, and you had to make compromises. So that's kind of what we're doing right now. Is we're making compromises. We realize that this is the state that we're at. We have medication request available, not the things that we actually need, because having a anti-diabetic drug in your med list is not going to help when you need to find out what happened 1 hour before it was actually given to the patient before they had a hypoglycemic event, for instance. So we just need to work together as a nation and try to get stuff that we need together that hits really all of our needs. Let me just quickly show something here to give you an example of what I'm talking about. So here is a page from QI Core that sort of lists the QI Core profiles, the US Core profiles that maybe they're based on, and what the base FHIR resources are. And we see a lot of gaps here, but also a fair number of incompatibilities as well, or just things, not really incompatibilities, but different groups making different choices, such as, if we go to, it's not a touch screen on this one here. If we go to like QI Core Encounter, we could see that here, they have encounter diagnosis flagged as must support. So everybody that's writing quality measures looks at this and they then try to pull encounter.diagnosis. But what's actually implemented in US Core, there is no encounter diagnosis in here. Rather, we have US Core condition. They have no encounter diagnosis condition that goes the other way. It points to the encounter here. So just being able to communicate all those differences and those little idiosyncrasies there to measure developers is more and more difficult. You end up having to write all these, deeply nested alternative CQL statements to get everything working today. I hope at some point we can do a little better, and maybe one thing that we had a similar problem for this when we were doing CDA implementation guides back in the day, where we had different versions of C-CDA out there from HL7, from HITSP, from IHE, all done in slightly incompatible ways. And also these other bunch of other implementation guides like history and physicals, procedure notes, etc. And as basically as a community, in the U.S. here, we came together and decided, okay, we need to get away from this point where we've got thousands of templates, which are profiles in FHIR, harmonize them and get back to a rational amount that actually met that core that we actually need. So anyway, that's my soapbox. I'll get off there for now. But it was eye-opening in Graham's presentation that there's over 700 implementation guides out there right now. I think we can maybe try to reduce those a little bit. So, yeah, let me just go ahead. So as I said earlier, we often have to go out to other sources for this data at this point. Another big challenge in public health is this push versus pull mentality we have. I'm not trying to say that public health people are pushy, but John Lunsk isn't here, so there. Public health has a long history with that push paradigm, and they're comfortable with sending data facilities and then catching the football. But when you try to say, well, why don't you just let us go in and query for the information, that's a big shift in mindset for them. And I'll just be blunt, not everybody's ready for it. The issues aren't so much technical for the most part, though there are a few technical ones, but it's more around policy, procedure, just people don't want to necessarily change the way they've been doing things for a long time. So we may need to compromise and have a mix for some organizations, which is why having an application that could sit inside a facility behind their firewall, run the queries, but they actually control what goes out and make sure that it's not, something they can maybe, again, it's a reference implementation, they can make tweaks to it if they need to. So it becomes more something they could own. That's one thought. Another one is if we get more and more support for FHIR subscriptions, at least some of the key triggering events that would point to, needing to generate a report could be done with a FHIR subscription, and then you have an application that could query back. So those are all, some things that could get around that, but it's still something we'll have to discuss for quite a while. Another big one is that EHRs right now have the limited ability to query across patients. We ran head on into this at the start of the pandemic when we said, okay, well, we want to query the EHR and find everyone who has a condition resource that points to a COVID-19 diagnosis or all their lab reports. And what you find is this. Let me go back here. Did I just... So basically, if you look at US Core for mandatory search parameters, it says you shall support searching for this with this patient parameter added to it. What it doesn't say that you can't have it without, just that you must support that. But if you look down this line here, every example in here shows querying with the patient. And so what does a lazy developer do? They make that required. And if you try to take off that patient ID and just query across patients for their conditions, you'll just be prohibited from doing that. So it means we have to come up with workarounds for things like this. Some EHRs, for instance, support the ability to define a list resource that is backed by a native query in their, whatever languages they support. But then, basically you end up with these, big hacks and workarounds to get at what could have been easily supported if you had that ability to search across patients. Another issue that we have is we often get more patient data that is needed. Again, I won't go back to that other page, but a lot of key search parameters that we would, think you'd rely on, like being able to filter by dates, saying I only want anything from, the first of the month to the end of the month. But if the EHRs haven't implemented those search parameters, then you end up getting, instead of just their conditions or their meds for this month, you get everything that's in that patient record. And then you have to rely on your measure logic or some other thing to filter out what you had to pull, because you couldn't pull any less, you couldn't be more specific, to what you actually want to report on. Again, sites, can mitigate this somewhat by setting up permissions and scopes and such to limit what is returned. We've actually run into this in some of our, work here where, we found you were expecting to be able to get all conditions, but, turns out they didn't give us permission for dental findings, which is fine. We don't need dental findings for this particular use case, but we weren't expecting to get errors back from those initially. But it did give us, insight into the fact that you can actually control and limit that access if you need to. So it's one more avenue for, limiting the patient data. But that's an area where we're just going to need to work more and more. Hopefully things like bulk data with type filter support would help as well. Just about out of time here. So basically our next steps will be piloting this new paradigm across many different sites, analyzing the results and reporting findings. And this itself is going to have its own challenges, because what we found here is, and it's been spoken to in some of these other sessions, is analysts are often used to rows and columns, not highly nested XML and JSON. And so we've had to come up with workarounds to help them flatten the data and analyze it in ways that they're used to, using their tools that they've often spent a lot of time and built much of their careers around. And lastly, I'll just continue championing expanded supports for APIs, resource support, more and more resources, CQL, bulk data, et cetera. Because really, we just need to broaden the FHIR support in general in a standard way that everyone can agree on. And the benefits will just keep piling on, not just for public health reporting, but, in my opinion, for everyone. So I'll go ahead and stop there. And any questions? Yes. So Dave just beat you by a second. So we'll go there, then there. Oh, and do we need the microphone for?
You can always repeat the question.
Yeah.
While they're doing that.
Oh, all right. Oops.
Or it is microphone.
Well, you assume that I have that I don't have short-term memory problems.
If you go back to slide 6,
Yes.
you've got the list of things in order. Is it 6? Yeah, there we go. So the first one, evaluated the measure resource.
So what I mean by the data requirements is the library, the library resource will have the CQL, and when you process that with some of the, like Alfora's tooling, it will say, this measure requires, condition, it requires encounter, and all that.
So you've already requested the condition, the measure before you do the data requirements.
Yeah. So
Okay.
really, that's just, I guess here. One of the first things we do on this slide is we pull the measure itself, and it's kind of hard to see. We pull down the measure, we pull out the requirements for there, and then that drives the queries.
Okay, that
Yeah.
makes sense. Okay.
So on this slide, the query to the EHR, is that done with CQL? Is that?
No. We're using just the native FHIR APIs for pulling the data out of the EHR, and then
So it's like
and then we pass that search set bundle or series of search set bundles to CQF ruler and evaluate against it.
I see.
Uh-oh, I got trouble back there.
No. So on the EHR side, some of the data are available on FHIR, some of them are not, like ADT and all of that. How do you get this data if you have different sources?
Well, some of it, like some of the ADT information you can get from encounter resources and such. In other cases, you got to do V2 to FHIR mapping, and that's what we do is, we can basically hook up to an interface engine, receive V2 feeds. We're not doing a lot of that right now. We're just sort of experimenting and thinking about it as we pilot, but we definitely see that as a need. And that's where our custom query plugin comes in. Basically, we'll assume we'll need to get stuff from a variety of systems and from a variety of data feeds as we begin. But hopefully, as time as EHRs implement more and more FHIR resources, which I've been thrilled to see happen. I was worried that we wouldn't see a lot of expansion of that. But you look at, for instance, Epic's FHIR site, and it was this many resources, and now it's this many, and it just keeps growing. So, I have a lot of hope that over time we'll need this less and less. And as new resources come online, we can retire some of those other custom connections and feed processing and such.
Any issues that you see with real time versus data that exposed with
I don't have enough time to get into that. All right, and KP, I think you had one, and then back to you. Yeah.
Rick, great, awesome stuff.
Especially.
It strikes me as something that CMS should be exploring this.
CDC and CMS are in a lot of discussions about it. We also got the Helios accelerator and US CDI Plus and all this other stuff where they're definitely talking about it, but there's still disconnects and mismatches that again, that's why I'm trying to say as a nation we need to harmonize and really come up with is core that we need for many of the use cases. And public health is a key one that is just, the public health folks are used to not being considered core for a long time. We're now fighting to get back. So,
Nice, good stuff.
Hi, can you speak a little bit to the plan for the pilots? So what use cases you're planning on and like what partners you're planning on engaging in the pilots?
Yeah, so some I can talk about, we've been working with Yale and University of Michigan, for doing the NHSNLink one. You can probably ask Dave about some of the other non-NHSN reporting works that's using this similar stuff as well. Most of the use cases that we're looking at right now are for things like like hypoglycemic events and such, adverse drug events, and then we'll be expanding that to things like hospital onset bacteremia, CDI, and a bunch of other use cases. So, but we're going to trying to keep it pretty limited, just a few measures initially while we tease out how all this happens. But so far we're pretty excited about it, and so are the folks on the CDC side. So. Okay, now someone's going to bash me for bashing
No, I'll hold back. Hey, have you compared this to the ECR Now app? It seems like there's some similarities.
There are a lot of similarities, and in fact, very early in our discussions, we were talking about can they really be one application, and there's just enough differences and enough, not just in the technology that they're using, like at APHL and stuff, but also in terms of their mandates and their what they're allowed to gather. So NHSN actually has a very broad mandate. Folks who sign up for NHSN reporting, basically they're allowed to get all that line level data, whereas like with ECR Now, they often won't get what goes in those reports back at the CDC, at that level. Maybe go to state and local folks back to the facility. So it really was just more policy than technical problems. But we keep trying to continue discussions with Don Linsk and others of how we can harmonize. If not necessarily the core application, if we can start changing some of those policies, then some of those the ability to share resources, share code becomes a lot easier. All right, anything else? All right, I'm a little over, but not too much. All right, thank you all. Take care.